you very much. Good morning, everybody. Can everybody hear me okay? Great. Okay, good. Happy Halloween. I see people bringing wine bottles in. Did they bring enough for everybody to share? I don't know about that. So it's kind of nice. Yes, thank you again for attending this session this morning. Again, I'm Brad Duncan from NorCal Group. I'm a senior risk management specialist. I used to think because that was my experience, but now it's my age. So in any event, we're going to be talking about medical ethics and patient encounters today. I have a couple of scenarios to share with you, and really it's about kind of building a framework or a methodology for when you encounter potentially difficult situations that are related to ethics. It kind of gives you a framework for working through some of the issues. How many folks here, before I get started, have, recently or even, I'm sure in your careers, have dealt with difficult patient situations involving ethical decisions? How many folks have worked with those kinds of things with patients? End-of-life issues, difficult non-compliant patients, involvement of patients, not only just patients, but also family members, siblings, everybody that gets involved. And also I ask too is how many folks feel that they have good resources in terms of if you have an issue that you can bounce it off a colleague or an ethics committee. Do the institutions that you're affiliated with have those kinds of resources for you? If not, hopefully that's something that you can identify to assist you with, because I think all these situations that we run into are dealt with on a case-by-case basis, because everything has kind of particular details that it's hard to make a blanket statement about one size fits all, and this is what we do in all circumstances. And so I think it's really good to have those kinds of conversations, because when we're dealing with the topic of ethics, there's a lot of things that are going on there in terms of there is not necessarily one or only one best way to deal with the situation from that standpoint. So let me get through some little housekeeping issues here. Basically, this is just a disclaimer on my part that I'm not an attorney. I can't give legal advice. I'm a risk management specialist. I should be able to say that real fast like they do in the commercials, And really, the objectives for today are pretty straightforward in terms of what we're going to be talking about. And I know we're pressed for time. This is a kind of a weighty topic to talk about, but I'm happy to be around afterwards to address any particular questions you may have as we're going through. And so certainly I'll be available for that. Really, it's interesting in terms of talking about ethics related to risk management, and then, some folks are saying, well, how does that really apply from that standpoint? Well, if I'll bring to your attention, everybody should have there are copies of a Claims RX publication that are on the ends of the tables. If you don't have one, feel free to grab one. The scenarios that I'm talking about today are included in that publication. Definitely take that along and, for reference and later on in terms of, going back over some of the cases or some of the points or risk management recommendations related to the case studies we're going to talk about. And I will draw your attention to one kind of key paragraph, which I think kind of sets the foundation for basically risk management and ethics. The two disciplines, risk management and ethics, are alike. This is on page 2 of the publication. Are alike in that both call for the scrutiny of information about patients' substandard experiences in healthcare, and both advocate the application of techniques that will reduce difficulties, conflicts, and problems so that patients' experiences will ultimately get better. That's what we're all about here. We all have that similar goal. An unresolved moral issue in patient care is a potential liability exposure. Therefore, recommending ways to resolve clinical ethical issues as a means of reducing overall lawsuit risk. So there's kind of a tie-in there with professional liability, which is the fundamental goal of risk management. We talk about things in this world that are beyond our control. And when we talk about risk management, we're really trying to take a look at some of those things and figure out ways to reduce liability exposure, reduce lawsuits, All the while, we as a professional liability company, and I think any professional liability company should share the goal with you as healthcare providers that you want to provide good patient care, you want to do what's best for the patient, and a lot of what we talk about today follows from that concept. Just as far as the objectives, basically differentiate and identify the behaviors that constitute ethical behavior, personal conflicts, and professionalism. Identify and apply bioethical principles in healthcare settings. We're going to talk about some of those as we go through. And apply ethical best practices to improve patient safety and reduce overall liability that focuses on identifying, responding to, investigating, and monitoring ethical behaviors. This is a topic that I think when you think about it and when I think about it, there are a lot of situations that I'm confronted with on a day-to-day basis from you when you call me as a risk management specialist and ask me to kind of troubleshoot an issue with a difficult patient, a non-compliant patient. There may be situations where, there has been a medical error that has occurred or an unanticipated outcome. And you're wondering, how do I bring this up with the patient? How do I approach the patient about this situation? Do I approach this patient about the situation? What do I say? And just recently, just as a minor example, I got a call this week from a physician who had a patient who underwent a biopsy back in January, came up with a basal cell carcinoma, I believe, like on the rib, and so but the thing is, in that situation, what happened was the test results never got to the patient, okay? And so they're discovering this 10 months later. Doctor's calling me saying, what do I say to the patient? Or what do I say maybe to the son of the patient because he came with his son last time? Do I bring this up or do I let them kind of ask questions? And this kind of puts us in a, kind of an ethical dilemma situation. I said to her that, first of all, the main thing is that they're taking care of the patient immediately from that standpoint. They're getting them in, they're getting further tests, there's going to be additional care with this patient. At some point, and unfortunately, in a circumstance like that, when they're talking to me from a risk management standpoint, I'm going to contact our claims department and I'm going to say, here's a situation that may be a potential claim because what if this patient files suit? Now, the things that have to come out of this are that is this patient's outcome any different due to the delay? That kind of goes to the claims concept of causation. And is there any injury? So, a lot of folks, and being that it's Halloween, I don't want to scare you all about lawsuits and things like that. Any of you that have ever been involved in a professional liability claim or suit, it is a scary situation, no doubt. I think that when I read the indictments or the allegations about how someone has been negligent in the care of the patient, I don't know how you all don't take that personally, from that standpoint, because I don't think that any of you wake up on a daily basis when you're dealing with patients and say, gee, who can I, maybe hurt today? Or who's my least favorite patient or something like that. You deal with a variety of patients and behaviors and things like that, but your goal is to, and what your mission is to really deal with those patients and do what's best for those patients. And we're going to talk a little bit about those kinds of things. So anyway, like I said, I would share that issue with our claims, and sometimes if there's early intervention with maybe an attorney or something like that before it becomes a claim, we just want to be all on the same table in terms of giving advice to that doctor. And then I said, when the patient comes in, you have to anticipate what questions the patient may ask, and if I were a patient, probably like you would say, well, how come I'm finding out about this 10 months later? You told me that if I didn't hear anything, then everything would be okay. And now you're telling me 10 months later. So that goes to another issue. We could spend another hour talking about follow-up, because since then, this practice has changed their follow-up procedures, because now they're making sure that they notify and track results much better from that standpoint. But that's an issue that we run into quite often, when I'm doing risk assessments of practices and things like that. So there's a weakness in that system, which kind of leads to these kinds of outcomes. Some of the biggest, these are just kind of a summary of some of the ethical issues you may face in your particular practice. End of life is at the top. That's the one we think about a lot because it's the one that gets a lot of attention, I think, in the media. We see news stories about that. You know, over the, you know, I live in California now. I'm originally from the East Coast. California just joined one of several states, or it's one of several states in the country that joined the bandwagon for assisted suicide in California. There was something that was passed by the House and Senate this summer, signed by the governor of California. I think there are about 5 or 6 other states in the union that have that in place. Part of it was prompted by a person by the name, I believe her name was Bethany Maynard. You may have heard about that situation where she was a resident of California. She had a terminal illness. She wanted to die with dignity, but that was not something that could happen for her, at least at that point, you know, several months ago in California. So what she did end up moving. She and her husband moved to Oregon. That's the state that does have this in place. They were able to, you know, fulfill her wishes in terms of what she wanted. And then her husband, you know, campaigned after that and during to, you know, see why can't we have the same kind of thing in California. And I don't know if some of you from other states, this is a topic of discussion or it's in the legislature being considered. Obviously, there are people that are against it because they feel that, you know, there could be people that want to undermine that situation and use it to their advantage to hasten somebody's demise or death, or, you know, there could be motives, you know, along those lines. But again, overall, the idea was to allow folks who have terminal illnesses, you know, and conditions where they have some choice in the matter in terms of how they die. So that's the kind of thing that gets a lot of attention. You know, we have reproductive issues, privacy of information issues, termination of care. That's probably one of the most frequent calls I get when you're dealing with, because I would say, so none of you folks have difficult patients, right? All your patients are compliant, do what you want, expect, everything like that. Well, no, I mean, that's something that I share that with you and that I deal with those things on a regular basis, you know, most frequently about, do we terminate care with this patient? What resources are available to this patient? How do I transfer care of this patient appropriately? You know, have we reached a situation in this relationship where we're at an impasse but the other side of that is, do we risk, you know, possible abandonment, you know, with that situation? And all those are kind of considered on a case-by-case basis as well. Dealing with surrogates and guardians, we're going to talk about one of the cases involves that. Personal moral conflicts. You can probably think of some others as well from that standpoint. So there are a host of them. Another case that, you know, got attention maybe about 1.5 years, 2 years ago when we first started doing this lecture on ethics was Jahi McMath. This was an Oakland Children's Hospital patient who I believe underwent a tonsillectomy, but then suffered some kind of a brain injury during surgery and essentially was considered to be brain dead from that standpoint. But the patient was on life support. The family said, you know, no, we want to, you know, basically keep her alive, and we think that, and you've heard it, you know, this goes back to the Terry Schiavo case many, many years ago. You know, that got very involved with politics and politicians and people in government even making comments on that in terms of, you know, right to life and death and that kind of thing, statements and beliefs. In this case, the child, who I think she was 13 or 14, was transferred. And she was transferred actually to a facility in New Jersey because the hospital was saying, you know, we in California, basically, we can certify that a person is brain dead and declare them dead, and the family was against that, so they moved the patient out of that facility. So every so often when these kind of debates come up, you know, we are kind of left thinking about, you know, how would we deal with those situations if we were confronted with it? You know, how it's very, very difficult from that standpoint. You know, you have your personal beliefs, you have the beliefs of patients, and you as medical professionals know that, well, I think for this patient, you know, the best thing is to let them go, let them die, because anything we do is not going to be medically appropriate from that standpoint. It may extend life, but really, what is going to be the final outcome from that circumstance? So every so often we do encounter these difficult situations. Another case I think about was a really interesting interview on 60 Minutes with a woman who was actually a nurse herself who had an elderly father. This was in Pennsylvania. And he was terminally ill with cancer. He wanted to die at home. That was his wish. That was really what he wanted. And so what happened was one day and he had hospice care at this time, one day when his daughter was there at home, he basically took an overdose of morphine. And he said, and the daughter didn't stop him. Basically, he kind of did it on his own. She did not physically assist him in that or anything like that. It did not enable him from that standpoint. And but when the home health nurse came, the daughter told the home health nurse, this is what happened. Well, the home health nurse immediately called 911 and called the police. And the daughter was arrested. And the patient went to the hospital. The patient lived for about 4 days and eventually died. That was not where he wanted to die. That's not what he wanted. Did anybody see that interview on 60 Minutes at all? That was about a year ago. Again, it kind of brings she was since exonerated from that situation when they looked at it. But again, Pennsylvania is not a state that has that kind of assisted dying in place from that standpoint. But she did not do anything to precipitate the patient's death. But again, everything went against here was the patient whose wishes were not respected. And we're going to talk a little bit about that as well, too. I was talking with some folks on, I guess it was Thursday evening, or time kind of runs together now, but we were talking a little bit about science, the science of medicine and the art of medicine. We've got all these great advances in science and in healthcare. We've got, our technical proficiency, our clinical skills. We keep up on those, on a regular basis. But then there's the other part that we deal with, which is a little less or a little bit more, there's the gray areas with respect to the art of practicing medicine, and ethics kind of falls under that category when it relates to, professionalism, decision-making, and those are the things, some of the gray areas that we deal with in some of these cases related to ethics as well. I think that we basically applaud some of the advances in medicine with respect to technology and the things that we can do to extend life or improve the quality of life. We have, I can't help but mention, though, when we're talking about technical issues, everybody thinks sometimes about their electronic medical records and how they love them so much and really enjoy using those. And I see head shaking sometimes. It's an interesting, that's where we're evolving with all these kinds of things. And we, even as a professional liability company, are learning, do these electronic medical records help us document patient care better and encounters? Do they or will they actually help us defend cases better? I mean, the jury's kind of still out on that, and from that standpoint, it's something that I know when I go out and I talk with you all, and actually, I learn about a lot these electronic medical records and the systems you use. And you tell me about the things that you're happy with, the things that you're frustrated with, things that you wish were different. And there's so many systems out there. There's a lot of stuff going on with respect to science and technology in healthcare. But we're going to be talking about kind of the art side of medicine. So let's talk a little bit about what ethics is, or what we think about in terms of ethics being moral courage. Some of these decisions that you have to make really does require a lot of courage on your part to talk with patients and have some of those difficult conversations. They're not easy, particularly when, we're talking about that disclosure example, and that is a disclosure matter. We really support that, from a professional liability standpoint, that disclosure discussions may be had when there's a medical error or an unanticipated outcome. But I say that with caution because I think that obviously before you get involved in one of those conversations with a patient, you want to, basically have all your facts, know what you're talking about. not speculate about what kinds of things happened or what happened that went wrong, or, because we know that in some circumstances, when I'm having a conversation with you about a disclosure where there's a medical injury or unanticipated outcome that's involved, this could possibly maybe precipitate a lawsuit from that standpoint too. So, we do that with caution, and certainly when the doctor with whom I spoke, is talking to the patient about that delayed, biopsy, and maybe the son will be involved, he might be asking questions. Well, the patient, it's important that the patient his needs are considered. The son's involved, if he has permission to discuss his father's care, that kind of thing. But still, these are the kinds of difficult, and I think that in some cases you want to say, this is something that we're looking into. We don't know all the facts. You certainly don't want to implicate yourself. It's really a kind of a little bit of a tightrope that you're dealing with. How many folks have actually had a situation where you had to do a kind of a disclosure discussion with a patient? Has anybody had that situation? Yeah, so you're familiar with this kind of thing. And did it work out okay from that standpoint? And did you feel that, maybe from the standpoint, we used to say, well, gosh, don't say anything at all. We might get sued. This is all. But I think, of course, the American Medical Association, medical societies, professional liability companies like mine, really, and our board can support the concept of disclosure within reason and with caution. And I think that those kinds of things typically do work out well because, information's provided. And in some cases, in those disclosure discussions, did you don't have to admit to it, but, did you actually have a claim as a result? Or do you think that maybe that claim was not tendered because of that discussion you may have had? So I see some head shaking from that standpoint. So, those are some of the possible outcomes from that situation. Dignity, we talk a lot about that, death with dignity, particularly for the patient. And we're going to look at some of those situations and some of the scenarios we go forth. Compassion. Obviously, from talking with you all, I really admire the compassion that you have for your patients and the care that you provide and the dedication and, just I don't know how you sleep at night sometimes with all the things that are going on and all the things that you have to attend to with patient care. And we really appreciate the fact that you're doing that. And, certainly having compassion for one another in terms of all having shared experiences. Collaboration, very important among healthcare providers because many folks are involved in the care of the patient. So obviously we want to make sure that we do have collaboration, communication. These are things from a risk management standpoint in particular that we have control over, or the documentation that we do, how we communicate with our peers and with other folks involved in the care of the patient. These are things that we do exercise control over in the event that something goes wrong and there might be a claim later on from that standpoint. Again, all these things kind of relate and fall into place. Managing complexity. When I was a graduate student in healthcare administration 25 years ago or so, basically, what we talked a lot about, and this is something that you deal with, is the complexity of healthcare and the complexity of healthcare organizations. And there's no doubt about it, I still believe that they are some of the most complex organizations in terms of all the things that go on in clinics, hospitals, medical offices, and just, there's a lot to keep track of. And, you are, as healthcare providers, you're lifelong learners. You're here learning new ideas and concepts, and that's something that you do on a lifelong basis. And there's a commitment to that. The art of medicine. What ethics is not, Then we're kind of looking at, the morality police. Talk about a scary picture. That's a little scary. Anyway, morality police. We're not the morality police in this case. The thought police. Again, because I mentioned that the pull the plug police. I think back to when I had a grandmother who passed away in 1979, and it was the kind of thing where I remember, as much as I understood at that point when I was 18 or 19 or whatever, that the doctors who were caring for my grandmother pulled the siblings together, including my mother, her sister, and her brother, and had a discussion about the fact that my grandmother sustained, severe brain injury, and that if she was disconnected from life support that she would die, and that's what did happen. But at that point, I mean, you know, they did have a discussion, and we heard a lot about that early on, this kind of concept of, you know, pulling the plug and that kind of thing. And what, you know, should people really be doing that, or should we, you know, extend heroic measures or keep people on life support, you know, that kind of thing. So again, that's something to consider. Religious thought police, everybody is raised with different values and morals. They play into how we approach some of the ethical decision-making framework that we're dealing with in certain situations. The right and wrong, because again, these don't come down, ethics is not a matter of what's right and what's wrong. It's, you know, by and by, it's really going to be what's best for the patient from that standpoint. And it may be something that you don't necessarily agree with, or I don't necessarily agree with from that standpoint, but really taking the patient's wishes and desires into consideration are very important from that standpoint. The how to treat your patient police, you know, there's no one way. The I'm in charge police, you know, in one of the scenarios we're dealing with today, we'll see a little bit about how, I think it was a surgeon who really feels like, you know, I'm the one that really needs to lead the charge here and determine what's best for the patient from that standpoint. And so we'll see how that worked out. The my way or the highway police, obviously not that situation either. Again, I mentioned this too, you know, a lot of times we talk about ethics as right or wrong, but it's kind of a balancing. And, you know, it's again coming up with better, more reasonable solutions given the circumstances. And hopefully, you know, in some cases there are multiple options involved. And that's something that when you all call me about these things, we go through these options and talk about what the best things are from that standpoint. But certainly, you know, I'm dealing with it from a risk management, professional liability standpoint. Obviously, you do want to consult if you have the ability to talk with an ethicist or somebody who has a lot more experience in that area. I don't consider myself an expert in ethics. I consider myself a student of ethics at this point as I go through and learn from you the kinds of things that you deal with on a regular basis and the challenges that you face. The bioethic principles that we're talking about, and these are some things that we apply to the case studies that we're talking about going forward. We have autonomy. These are the things where, again, remembering who the patient is, valuing their input. Does the patient that you're working with have the capacity to make informed decisions? We're not talking about competency. Competency is a court determination from that standpoint. But on a regular basis, I get calls from you all saying that you know, you have an elderly patient whose children are saying, we want you to, you know, certify that mom or dad is, you know, has dementia or Alzheimer's, or they don't know what they're talking about or what they're doing. Well, those kids are not your patients. You know, the patient that you have, the elderly patient, and we don't discount an elderly patient's wishes just because they're elderly from that standpoint. I think some folks have that perspective, but we certainly shouldn't do that. And if they have the capacity to make informed decisions, even if those are decisions that we don't agree with, that's their right, you know, from the standpoint of autonomy. We talk a little bit about beneficence. Again, what would be, you know, best for the patient, doing what is best for the patient along those lines. Non-maleficence, that's a hard one to pronounce. Basically doing no further harm to patients. You know, one of the things that where if surgery was considered to maybe improve someone's life or extend life, even by doing surgery, in essence, if we are doing something interventional or cutting into the patient, there could be harm to that patient. So, you know, we have to consider whether or not, you know, it's beneficence or now maleficence that we're dealing with from that standpoint. And then justice or fairness. This is a kind of a difficult concept when we talk about, particularly if it comes down to a personal level, you know, but we do think about situations like, you know, patients that may be on life support indefinitely. Is that a good use of those medical resources, or could those resources be better used in other areas? And I know that's really a difficult conversation to have, particularly with a family, you know, when we're dealing with these kinds of things. You know, we want kind of fairness in healthcare, So those are the kinds of things that sometimes come up. You know, you'll hear folks talk about the cost of keeping someone on life support and you know, when there is going to be no good outcome to that patient. You know, and sometimes there are, you know, when I was talking a little bit about, I go back to the right and wrong situation, I think you all heard. Now, definitely, here's a situation that was definitely awful. This was a few months ago, I think. The doctor, who was, I believe, an oncologist, was diagnosing patients, giving them a cancer diagnosis, and then putting them through radiation and chemotherapy treatments when these patients did not have cancer. Did you all hear about that particular doctor? Yeah, I mean, now this is not an ethical debate at all. That's just clearly wrong. It's illegal. It's immoral, you know. That doctor, I think, is in jail now, right? So, and if there's one out there, maybe there are others. And it's terrible because people see that, and hopefully, you know, you have this relationship with your patients. You know, you have this basic trust relationship. That's one of the most fundamental, important things that you have. But when folks are out there seeing this kind of thing happening, you know, they may wonder, you know, what's going on, and would you expect a professional physician to be doing these kinds of things? How did that person get so off course, you know, with their moral compass to, you know, to enable them to do that kind of thing? It really has my mind boggled from that standpoint. Talk about not being able to, I don't know how that person could sleep at night. But anyway, those are kind of the challenges or the bioethical principles, and they're described in that Claims RX for later if you want to go back and refer to those. The ethical challenges of medicine, obviously patient-family expectations, we talked a little about that. Community standards in terms of things that are happening in the community, the state, the nation, laws and regulations. You know, as I mentioned, you know, we have some states where they do allow death with dignity. It's really, and that's what they really are calling it. Instead of assisted suicide, it's more death with dignity from that standpoint and what's involved with that. And there are obviously laws that are built into that in terms of how you do that appropriately. And then sense of failure or surrender. You know, I know that you probably have patients that you work with that you recommend something and they decide to decline your advice and you disagree with that, but then obviously you document that. Maybe you want to get an informed refusal like you get an informed consent. But you probably may feel personally that it's a failure because you couldn't convince that patient to make a decision otherwise. But again, they're exercising their autonomy, you know, from that standpoint, and we may not agree. But at least you've done the job of laying out all the options and you've tried to, as part of that, informed consent. This is the risk, benefits, alternatives. If you do this, if you don't do this, this is what can happen. So again, I think there probably are some frustrations. Have any of you had those situations where you recommended something to a patient because you felt it could improve the quality of their life or extend their life and they said no? Has anybody dealt with that situation? I see some heads shaking. Yeah, so it's very, very, very difficult from that standpoint. But again, as a medical professional, you know, you laid it out for them. Goals of medicine, and this is related too in terms of, you know, typically we want to return the patient to full quality of life, get the patient to an acceptable quality of life, if that's the case, and that may be not full quality. There are patients that want to be able to do certain things and they make that known, and if that's possible, we have an acceptable quality of life, and provide comfort when quality of life goals cannot be achieved. So we have to ask ourselves, what's the goal? And then, you know, I mentioned this a little bit earlier in terms of the beneficence and maleficence issues are assessed in terms of, you know, looking at how things balance out, you know, from the standpoint and what's the best way to proceed. Then we talk a little bit about, related to some of these ethical decisions, you know, is something medically indicated? That's a question that we ask. You know, is the patient acute, chronic, critical, reversible, emergent, or terminal? What are the goals of treatment? We mentioned those just before. Is it medically indicated? You know, you have patients that come in and tell you all sorts of things they want, you know, because they've looked it up on the internet, and this is what they think is best, and this is what you should do for them, right? And of course, you probably have the patients that come in and tell you what kind of medications or narcotics they want too. That's a story for another day. But anyway, you know, that's where there are some red flags that are raised. But when you have patients that And you should know what's out there from that standpoint, but you are the doctor. You're the healthcare provider. You're the one that says, yes, I appreciate that, but this may be something that does not benefit you, and you have to rely on my insight as a medical professional to talk to you about these kinds of things that you're proposing. And you don't necessarily have to do those things that they're requiring. And you may come to an impasse in the relationship too. What are the probabilities of success? Sometimes we have those, in terms of data that we can share that help you with making decisions. And, how can this patient benefit from care? Are there benefits to the patient? And again, bottom line, how can harm be avoided? So where do problems happen, or where do ethical problems happen? Well, they happen when the goals are undefined, they change, they're unclear, or there's conflict. And we run into all kinds of these kinds of things, and we're going to see some of that in the case study. Just real quick, this is kind of with respect to how we deal with things in terms of our personal life and our personal values and beliefs. There are certain things that we believe that we don't feel that we can do for patients because it violates our religious, moral principles, that kind of thing. So, that's kind of on a personal level where, you can excuse yourself from the care of the patient if they're asking something that you don't agree with from that standpoint. And you do that appropriately from that standpoint. Then there's the value conflicts. The example there, in working with my colleagues is that, basically you have a situation where you have, say, for example, hospitals that are affiliated with the Catholic Church. Well, now the Catholic Church is coming in and removing the affiliation from those institutions because they're engaging in doing certain things like abortions, contraception, that kind of thing. So they remove all the icon. Maybe they keep the name, but it's still not affiliated with the Catholic Church because that's against the values of the Catholic Church from that standpoint. So we have personal matters as well as institutional matters. Okay, so here we have a situation, this is one of the first cases where we have an advanced heart failure surgeon wants to place a pacemaker in a 77-year-old male with diminished physical capacity but intact mental capacity. Daughters are adamant about doing whatever it takes. So the daughters feel they want to do whatever it takes. Now, the situation in this case was that a lowly resident happened to have a moment alone with the patient and the wife, and they expressed the fact that they did not want the pacemaker and that they realized what the consequences would be of foregoing that treatment. But this is what they wanted, from that standpoint. And the resident, thankfully, documented this conversation, very important, so that when, and then the surgeon basically was looking to not the patient, but was looking to the daughters as decision makers. Well, kind of leaving the patient out, leaving the patient's autonomy out of that in terms of what he wanted for himself and what he wanted with his wife. So there we had to kind of, this was a situation that was presented to an ethicist, and a number of folks discussed it, and the resident brought up the situation and said, this patient said this is what they want. And so it really kind of turned things on its heels a little bit, probably with the daughters and the surgeon. Now, the surgeon is not being a bad guy in this situation. This is what he or she is trained to do. They want to help this patient, and they think that this could, prolong the patient's life. But this is something that it's against the patient's wishes. And again, hopefully they're making an informed decision along those lines. And so, so what would you all do in this situation? Confirm with the patient their wishes and honor his request. That's the first choice. Perform the surgery because failing to do so would result in a lawsuit from the daughters. Consult with clinical team to determine the best course of action, then proceed with a final decision. Or bring the daughters into the family meeting with the patient to talk some sense into him and the wife about the decision. How many people which one do you like the most?
I'd like to get the ethics committee involved.
Oh, there you go. Okay. There you go. That's good. That's good. Well, we did in this case. And so of those, I would have to say, or does anybody else want to make an actual choice on these? Don't worry, you won't get in trouble. It's hard. Basically, I think in this case, based on the discussion we've had so far, we want to confirm with the patient their wishes and honor the request from that standpoint. The other ones, yeah, I can see where a doctor would be concerned, because if there are options available, and you don't do those, the family members come back and say, my mother, my father died because you didn't do this, and why didn't you do this? Well, the resident had that conversation with the patient and the wife, and this is what they want. And, you may have even seen this. One of the most heartbreaking things I just saw was a little 5-year-old girl has a terminal illness. This was in one of the news stories. And she has these bouts where, she has to go be hospitalized. It's very difficult. And she's at the point where she told her parents, next time this happens, I don't want to go to the hospital. I want to stay at home. A lot of times we're talking about older patients or elderly patients. Here we're talking about a 5-year-old. Now, does a 5-year-old have that capacity to make those kinds of decisions and understand the consequences? Not necessarily, but, we're listening to her. The parents are listening to her. This is what they want. But, don't they also face the possibility that if something happens and they keep her at home, that Child Protective Services said, you should have taken them to the hospital. So then you get these other, court involved and that kind of thing. So, I guess they had to be kind of careful about how they maneuver that, and if they do respect the wishes of that 5-year-old. But this can happen across the board no matter how old someone is from that standpoint. So yeah, we're going to go with A on that. We're not going to try to make them change their mind, that kind of thing. So here's the, kind of this framework that's kind of common to the case studies that we talk about. We're talking about who are the key individuals involved. We're talking about the surgeon, the daughters, the patient, and his wife. What are the intentions? We talked about what everybody has kind of different perspectives on that. Those are where some of the conflicts are. But again, we go back to listening to the patient. The ethical principles, justice, beneficence, that kind of thing. What are the bioethical principles in this case? The patient basically may have extended life, but not necessarily quality of life. So, are we actually, in essence, by installing the pacemaker, could it be considered harm to that patient? Again, we want to respect their rights along those lines. So these are, again, it's kind of the how you put it into the framework and look at it. And then, is it the medical indications, the clinical options and the consequences from that standpoint, and what's appropriate. And so basically the patient's wishes were respected, and the patient, did not. But again, it was really helpful that someone had that conversation with the patient, listened to the patient, and that was brought to the forefront from that standpoint. And so, there's, again, we're hitting the highlights on this. It's really, you can think about the time that was needed to, get involved and have discussions, and also, again, document those wishes as well, so that it's clear in the record that the patient, who is of sound mind and has the capacity to make, is choosing these options, so that it's clear, going forward, that if anything's challenged, you have the patient's wishes there, from that standpoint, and documented in the record. We're risk management and the law, and again, I'm not an attorney. Some of the stuff I talk about sounds like law because I have to be aware of statutes and things like that. But when we talk about ethics, there's the should do, the law, which is have to do, and risk management, what we choose to do in some cases in terms of the options. Oh, was the little, there we go. Operational considerations in ethics, again, culture of ethics, in the organization. Do you have an organization that supports you with respect to ethical decision making, and do you have someone you can go to, from that standpoint? How do you deal with conflicts of interest? How do you deal, what are the resources and finances that are available? These are things that come into some of these discussions. Insurance payment, who's paying for care? What if the provider refuses to provide services? Allocation and utilization of services. Again, it goes back to that, how things are, from the justice or fairness standpoint. Competency and capacity, I talked a little bit about that in terms of competency is more of a court-determined matter where, you're dealing with a patient and, you believe that you have the ability to communicate with them and they can make informed decisions. And so, you listen to them from that standpoint. Refusal of treatment, I talked about Just like informed consent, you may have informed refusal when someone refuses. If you want a copy of an informed refusal document, I can provide that to you. I have an email address. Or if you want to come to me later, there are other resources I have available along those lines. Unclear who the surrogate is. There's advanced directives. This is another issue that comes up. Sometimes they're not there, so what do we do? And what if the patient's wishes are unclear or not consulted with? This was just, real quickly, a 55-year-old female patient with end-stage COPD, and she was admitted with shortness of breath and unconscious, and she was placed on medical ventilation. She was in the MICU for a month. She did actually become conscious during that time period, but she did need TPN. But when she became conscious, she couldn't speak. She was aphasic, but she did say, or did write, that she wanted the TPN stopped. Now, obviously, the hospital was concerned that if we do that, the patient's not going to survive from that standpoint. She needs that feeding. And at that point, too, that's my alarm to wake up. Excuse me. All right. So anyway, they were unable to term a surrogate in this situation. And as I said, the patient was likely to pass away. So on this situation, obviously, we have an ethics consult because the patient's no longer being sedated. And again, it goes to her autonomy. She's alert, and she can make her wishes known, whether or not she can speak, but she can write those things. She is alert and oriented. She's making a refusal of the TPN, and she wants to go home. And so we kind of put that in the analysis, and what are the options? TPN and hope the ileus resolves and stay in the hospital, discharge on home medical ventilation. Well, that can be pretty difficult from that standpoint in terms of care for that patient, and does the family realize what's happening or what's involved in that kind of care. Provide her with reasonable efforts to make her comfortable and home hospice. So ethical issues are patient's capacity and autonomy, determining who the surrogate decision maker is in the event that she becomes incompetent. In this case, there were several folks involved. I think she had a live-in partner. She had there were a couple other family members involved. And I think in this case, if I remember correctly, she made her daughter the surrogate decision maker. And again, that's important to keep in mind because, a lot of times you're confronted with folks that they say, well, I have a power of attorney for my mom or dad. Well, that's not a healthcare power of attorney from that standpoint. And even then, healthcare power of attorney for decision making is only enacted when the patient is incapacitated from that standpoint. It doesn't override their wishes from that standpoint. So again, like I said, there were multiple folks involved. Patient chooses something that will result in her death, and she understands that. So what do? Utilize the family to encourage the patient into taking TPN, recommend a palliative care consultation because the patient is actively dying and is refusing necessary services, get a court order to preserve the patient long enough to be transferred from the facility, or become a conscientious objector to the patient's decision, sign off on care, and transfer care to another physician. Which one do you like of those? Any thoughts? You want to say?
I probably would recommend a palliative care consultation because she's going to be actively dying.
You win the prize. Yep, there you go. Again, those are options, right? We're laid out the options. Those are options, but what is the best option? And I didn't say what is the right option or the wrong option or anything like that, but I said, what is, and that's what, the situation was in this care. The recommendations, palliative care consult, patient's actively dying, there's no chance of cure here, and they did have a discussion, and they opted for the patient going home and having home hospice care there, with the provisions of what would be involved in that. So the clinical considerations were, the curative versus futile treatment. This patient had multiple comorbidities, pain. We want to make, in those circumstances where patient chooses, it's an end-of-life matter. Obviously we want to make the patient as comfortable as possible, given what they have chosen. We have life-sustaining technologies, but do we necessarily need to use those in all circumstances? We question that. And so, it's really, and here we have, allow the natural death, withdrawal, withhold treatment, or life-sustaining treatment versus comfort care. And these are the issues that we're faced with in these circumstances, and we have to kind of go through all those. This is the last case here, because we're running out of time here. 47-year-old male found unresponsive for approximately 20 minutes, now in the ICU for a week. This was due to a brain or a drug overdose, and the patient has minor episodes of breathing, is on a ventilator. Physician recommending removal from the ventilator. Mother and sister do not want that and kept the patient full code, okay? And there's no advance directive. So the mother and sister are involved in this situation, and they feel very strongly that they want to give their brother and their son a chance to recover from this, which we know, given the circumstances and everything from the clinical standpoint, is futile. And so, but this has come up when I've had other groups talking about, we had to be careful about those conversations, because sometimes, when does the mourning process is kind of starting maybe for this mother and sister, because they realize, and we're saying, take them off life support. That's the best thing for them. I'm not ready for that, And folks have said, you have a situation where you want to give some time, let them to begin that mourning process, that grieving process, communicate with them, be compassionate, death with dignity for this patient. So, from that standpoint, what do we do in this circumstance? We were dealing with this situation. Here's the ethics consult was requested. We understand there's no recovery from the brain injury. There's no advance directives or documented wishes, so we can't rely on that. And the family is requesting care that was not medically indicated. And that's the frustration where, they're saying, well, we've got technology, or we've got this ability to keep the patient going, but this is just not, but part of that is, it's not just what you know up here, it's what you know here in terms of being compassionate, in terms of explaining that to the patients. It's another alarm there. I got a few minutes here. Family wanted to take the patient home, and of course, patient being on the ventilator, do they really realize what they're asking for in this circumstance in terms of the care that would be involved for, really something that's not medically indicated? But we have to, given the circumstances, we want to be compassionate and respond to their concerns, but then try to convince them that this is, the best thing to do. So the ethical issues, what's in the best interest of the patient, providing scientifically futile care, keeping a full code status on this patient, which is really not appropriate in the case, and then unrealistic expectations. That's the other thing too, that you're having to do with, because you may be giving them all the facts and figures that they need, but there's the emotional aspect too, that you have to speak to that as well. And trying to get them to understand that this is what the case is, because it's a heavily laden. So how would you respond to the family? Explain the clinical condition and likelihood of recovery, consider palliative care, allow the family time to grieve, empathize with the complexity of making this decision, attempt to frame the conversation with positive language, or all of the above. What do you all choose? There you go. Go to the head of the class. Now, the thing is, too, I think that one E is important, too, because it says, attempt to frame the conversation with positive language, because in this case, the mother in particular feels like, if you're killing my son, if you take him off life support, you're killing my son, okay? And you have to kind of change that thinking around. The patient is going to die, yes, but let's not put it in those terms. You try to assuage it a little bit, to make it a little bit more positive from that standpoint. And even given the circumstances, that's difficult, But using some of that, and the empathy is very important. So we've already covered those things. Communication issue is so important. You all know that in so many ways. We have so many ways to communicate with one another. Are we doing it better? Not always, but that's something that we do exercise a large degree of control over from a risk management standpoint. And so as a synopsis, basically this is the thing. With respect to ethics, and this is a topic we could talk about for a couple hours. Do you all want to do that? No, I'm just kidding. I know you've got a law conference, and we got other things coming up here too. But it is, it's really something that hopefully, in going through some of these cases, generate some thought as to, and how you have approached these things, because you all are the experts in dealing with these things, from that standpoint. I can talk about it academically from that standpoint. You've dealt with it personally. Although I will take that back. Actually, I did have a person a very dear friend of mine who died from a terminal illness recently, and I thought a lot about some of these issues, from that standpoint. But you may encounter these things more frequently from that standpoint. So hopefully, again, this kind of gives you an algorithm or a framework for looking at those circumstances. Taking into consideration science of medicine, the art of compassion, listening to patients, and excellent communication and documentation. Ethics is rooted in conflict. We saw how that happened in some of the cases that we talked about. And it requires difficult conversations. And even more difficult choices in some cases. And I don't envy you in those cases. It's easy for me to advise what to do, but you're the one that's on the front line, talking with the patient, talking with the family members, dealing with their difficult questions and dealing with their emotions and everything else that goes with it. And ethics is not for the faint of heart, or we'll say ethics is not for sissies, right? And that's my little overview of ethics. Any questions? Yes?
You comment on sorry works.
Say that again?
You comment on sorry works.
Sorry works, if I understand that, you're talking about like disclosure, where apology, that kind of thing?
Philosophy, they published a book that talks about avoiding some of the tactics that risk management normally finds to implement and say, go to the patient, say, we're really sorry this happened, I'm going to make this right.
Right. I mean, I from a professional liability or risk management standpoint, I support that from the standpoint of disclosure or whatever you want to call it. Sorry works. You have to be careful though in some of those circumstances too. We say from a risk management standpoint, I talked about empathy. When you encounter an unanticipated outcome, a death, a poor outcome, where you go in and okay, so if you're going in there to apologize or be sorry, are you the one that actually has the ability to do that? Are you apologizing on someone else's behalf? You have to kind of be careful about your involvement with that patient, and you're empathizing, because there are, like in California and probably other states I'm aware of, that in statute it says, if I go to the patient and I say, I am sorry this happened to you, that's different from saying, I'm sorry I did this to you, okay? That one is going to be the one that they're going to bring up later on and, use in the case. Saying you're sorry, yeah. But again, every case is a case-by-case basis. I'm sure I did not read the book, and I should, but I think that's probably what they talk about, that you have to keep all these things in mind. What if you're involved in the care of the patient and somebody else, one of your colleagues made the error, and you go to them and say, I think you should say something to that patient, or I think you should apologize. We'll do that next year. We'll do a discussion on disclosure.
That would be a great topic for next year. Why don't we give Brad a hand, and thank you so very much for coming.